So good morning, and thank you for the invitation and for the opportunity of present our work. I'm Dr. Scuderi, and I'm from San Raffaele Hospital, Milan. Today I'm presenting our work. There is PSMA-radio-guided surgery detecting nodal metastases during robot-assisted radical prostatectomy. So the prostate-specific membrane antigen, PSMA, is a transmembrane protein highly expressed, especially on prostate cancer tumor cells. PSMA can be safely targeted using the gamma-emitting radionuclides, and among them, the 99M technetium PSMA imaging and surgery is a valuable option at a relatively low cost. This is our study design. This is a phase 2 single institution non-comparative trial prospective study enrolling patients with non-metastatic prostate cancer disease with a risk of lymph node invasion more than 5% according to the Briganti nomogram. The study aims to optimize the synthesis of 99M technetium PSMA imaging and surgery and to assess safety and tolerability of the administration of the tracer and to describe the use of this new tracer in prostate cancer patients. This is the surgical plan. We start enrolling the patients, then we give the patient is receiving PSMA PET imaging within 30 days before the operation. Then the day before surgery, the patient receives the injection of 99 technetium PSMA imaging and surgery, and then the radio-guided surgery is performed. Here we can see that basically there were no adverse events due to the tracer's administration during the surgery. And then we go to our surgical procedure where we use a drop-in gamma probe that was used to measure the in vivo intraoperative activity and was moved using the grasper, we will see later. And we defined a positive finding as a count rate of at least 2 times as compared to the background. So video now. Can we please activate the volume?
After isolation of the seminal vesicles, the peritoneum was re-incised and the bladder released laterally until the endopelvic fascia and the ureters were identified. This allowed exposure of the pelvic lymph nodes. At this point, a drop-in gamma probe was inserted through a 15mm assistant port. It can be autonomously grasped and directed by the console surgeon using the robotic ProGrasp forceps. Externally, a control unit provides both acoustic and numerical feedback as a response to 99M technetium activity and can be used for intraoperative surgical guidance. Fibrofatty tissue within the operative fossa was removed, and the dissection was performed from lateral to medial up until the umbilical artery, and the bladder wall represented the medial limit. Similarly, lymph nodes along, as well as medially and laterally to the internal iliac vessels, were removed. Pre-sacral nodes were also removed. After removal of the fibrofatty tissue, ex vivo gamma measurement was performed to immediately confirm the removal of the lymph node lesions and to prompt further search in case of missing signals. After completing the prostatectomy, the gamma probe was used to assess the presence of 99M technetium PSMA imaging and surgery uptake in the prostatic fossa. And at the end of the surgery, the prostate and seminal vesicles were also measured ex vivo.
So this is the final nodal assessment for the 62 patients that were enrolled. 33% had positive nodes at PSMA PET, 16% as positive nodes during radio-guided surgery, and the pathological N1 stage was present in 34% of patients. Also, the perioperative outcomes were similar to those reported in literature with conventional robot-assisted radical prostatectomies. And those are the performances in which we can see that using the PSMA radio-guided surgery was giving us less false positive, but instead it was increasing the false negative rate, as we can see here. And with regards to the per patient analysis, the sensitivity, specificity, and positive predictive value, negative predictive value was 67, 85%, 70%, and 83% for PSMA PET, whereas the radioguided surgery showed a sensitivity of 38% and specificity and positive predictive value higher, meaning that were 95% and 80%. And we repeated the same analysis for a per region template, showing basically the same results. And we also interesting shown that the positivity, the false negative nodes were more likely to be where there were small nodes, less than 5 millimeters, at pathology analysis. In conclusion, robot-assisted radioguided surgery is safe and a feasible procedure, and it can enhance our ability to detect the positive nodes during robot-assisted radical prostatectomy. However, it's still characterized by suboptimal sensitivity, especially in micrometastatic disease. Thank you.
Thank you very much. Are there any questions from the floor? Yes, sir.
So what is the which you take to do this entire thing intraoperatively? Do you need to spend a lot of time on that?
We estimated it's between 10 and 15 minutes more. And there's also a kind of learning curve for this. It goes shorter and shorter. For after 50 cases, probably we were like around 10 minutes. It just requires to put and take off, and the analysis is like not taking so much time more.
And did you also check the PSMA PET was negative, yet you remove the node and check it? I kind of missed that slide where you mentioned the
specific what we always do is first we do the PSMA PET before surgery within 1 month. Then we do the radio-guided surgery, and once we remove the nodes, we go back with our instrument, and then we try to find both in ex vivo. We look whether we have removed that nodes, and then we go in vivo again to see whether we have completed our resection.
But your correlation was based on the final histopathology, or was it based on these two things?
Say again, sir?
Your calculation of sensitivity specificity was based on the final histopathology, or was it?
Was on the final pathology.
Final pathology.
Yeah.
That part of slide I did not see how many were actually positive on histopathology.
Okay, it was a report. We can go back later if you want to look at that better.
Yeah, good presentation. My question is, you only remove those lymph nodes which are showing the signal for the PSMA PET or PSMA avid lymph node, or you remove the rest of the lymph node only?
No, it's a standard extended lymph node dissection. So, and then we remove the obturator.
Suppose there is the right side, there is only one area which is showing PSMA avid lesion, and that is showing signal. So will you, after removing that, will remove the rest of the lymph node and left side also, or only that area?
No, we remove all of the bilateral nodes. We do a full lymph node.
So then what is the advantage? Like if you are saying the PSA avid lesion is there in our design template, which we usually do, then we are going to remove that template.
What is the final message? This is basically that for patients that show no lymph nodes at the PSMA PET preoperatively, probably those are the patients that might not need to do the lymph node dissection, or should utilize like the nomograms to assess the risk. But when we have positive nodes at PSMA PET, since there is a high probability that that could be a false positive, we can use the radio-guided surgery to intraoperatively confirm, because he has high positive predictive value. So we can be sure that that's a no.
So if it has such a high predictive value, then you should remove the area which is showing signal and leave rest of the lymph node and rest of the area, because that is not showing signal.
Yeah, that's ideally how we should do.
Okay, thank you. Our time's up. So thank you so much for that.
Huang. I'm a urologist in Swedish Medical Center at in Seattle, Washington. So this is going to be a how-to guide on how to do a robotic RPLMD. And a lot of the credit goes to my former fellowship director, Dr. James Porter, who helped to pioneer a lot of this work. So this is a 17-year-old male with a left-sided non-seminoma. His pathology was embryonal carcinoma, and there was a 3-centimeter periaortic lesion on a PET scan. So this is the docking. Really, the key to this operation is the setup. And you really want to kind of identify the key anatomic landmarks. And you really start off with this peritoneal incision. You open up the peritoneal flaps to expose the great vessels. And then you mobilize cephalad all the way to the duodenum. And that's kind of the cephalad extent. With these peritoneal flaps, you can use a 3/0 monocrol and really suspend them up to the abdominal wall. And I can just forward this video in the sake of time here. That's the suspension suture that you use to tack the peritoneal flaps anteriorly. And really, that should be the view where you have the great vessels exposed. So these are just some of the indications. So for stage 1 non-seminoma, you would do a bilateral dissection. And then for a unilateral dissection, it's typically done for stage 1 disease. And you do a frozen and decide whether or not you want to do a bilateral dissection. We advocate for a en-bloc resection, so starting with the retrocaval, interaortic, and then the periaortic. So this video really just highlights kind of the key steps. First, with the retroaortic dissection here. And the video really shows the 4 key regions where you want to control the lymphatics because there's a really high risk for chylous leak in these operations. And identifying the postganglionic fibers in order to preserve sexual function. And these are young men, so it's really important to preserve these fibers when you can. Right here in the interaortal cable region is the cisterna chyli. So really, this is a key region where you need to control the lymphatics, or you may end up with a bad chylous leak. I'll just skip forward a bunch of these. So, it's about a 5-hour operation. Patients go home the next day. They do really well post-op. This is a case series of 20 patients that we did. If you look, about 8 of these had retroperitoneal disease. Those all embryonal and teratoma. Only 2 of them had a recurrence. Those 2 recurrences ended up with chemo, and they had no evidence of disease at long-term follow-up. So really, it's a technically challenging operation, but with the clear instructional video, this hopefully will allow more urologists the ability and access to this operation, help benefit more patients. This linear port configuration really simplifies the access. You don't need to reposition the patient. You don't need to put them in flank. And doing this en-bloc approach helps to reduce the risk for chylous leak. And that's about it.
Great, thank you very much. Are there any questions from the floor?
So I saw for suspending that peritoneal edge, you took a bite with the suture and you kept the needle inside. So we are following this technique only. I saw that James put a paper around 7-8 years back in which you explained that ports for XI and SI differently. So what we do in these cases, I don't know what is your experience for that. So take 3 different straight needle stitches and keep the needle outside, so that you don't have to worry about the needle inside, because with the 4th arm you're retracting the bowel up, coming from the right side. You're retracting the bowel up, and needle does not injure in that case, and your assistant can simply pull the thread out so that it keeps on retracting. Our main aim for these cases are post chemotherapy RPLNDs for testicular tumors. But sometimes you have to remove that stump of the cord, and if you have to do a pelvic node also in that, so you have to rotate the boom in XI, and you can do with those ports only. But do you have, if you are planning that thing also in mind, do you change any port positions, or with this only?
Yeah.
I've done a couple of cases just by rotation of boom. So I just wanted to know if you have any change in the port positions, if you are planning to do that as well. Because that helps, that thing comes into play for gynec cases also as well.
Yeah.
So they have to do hysterectomy for endometrial cancers, and for that also.
Yeah. So the first part of your question, using a needle, like a Keith needle from the outside, also works. So as long as you suspend those peritoneal flaps and you have access to the aorta and the cava, then that's perfectly fine. The second part of your question, with the XI and the ability to kind of reach back, it really revolutionized multi-quadrant surgery. So with this linear port configuration, the arms can actually go back on themselves, and you can reach the cord and you can dissect out the cord in its entirety without redocking.
And if the lymph node is situated on the right side, do we still do this position, or you can do in right flank position? Because we do it in right flank position if we have to remove that lymph node.
Yeah, so that's really the benefit of this approach is it's flexible. If you want to do a unilateral, you can do unilateral. If you do frozens and you realize there's disease on the other side, you can do a bilateral without having to redock or anything. So it's a very versatile approach.
Last question.
Is your preference transperitoneal all the time, or you do retroperitoneoscopic RPLND also? And any advantage of doing transperitoneal?
If you're going to do bilateral, then I would say you have to do transperitoneal, so you can you can reach both sides. If you go retroperitoneal, then you have to do it separately.
Okay, thank you very much. I think that's a wrap.